through the pelvis and the women's health issues. And to start with that, you need to know what's normal. Because if you don't know what's normal, you don't know if you're abnormal. You don't know if you're really having any problems or whether it's just somewhere in the mix there. So what is normal? So normal is having no incontinence. So being able to control your bowels, so controlling poo, so the solid, any wind, any liquid that comes out of there, and also the bladder as well. So with the bladder, you're looking at going maybe 6 to 8 times over the day, maybe once overnight. With your bowels, it can be anywhere from a couple of times a day to a couple of times a week, and it really depends on the consistency of your stool as to whether what you're doing is normal. So ideally, you're looking for that sort of type 3, type 4 in the middle there. So typically like a sausage, should be formed, relatively soft, should come out nice and easy. So if you're sitting up at the top of that type 1, the little hard pellety bits, we've got some issues, you're not getting enough fluid or fibre, it can be quite hard to get out. And if you're looking at down the bottom where that's quite loose and bushy in the diarrhea, then you might be losing fluid and dehydrating, not digesting your food properly, and that can also lead to urgency incontinence as well. It's not normal to strain, and that's for either the bladder or the bowel. And it's also not normal to have any urgencies. That feeling of, oh my God, I'm just going to go to the toilet right now. That's not normal either. Okay. So what can go wrong then? So pelvic floor muscle dysfunction is something that can go wrong, and that encompasses anything that's going wrong with the pelvic floor muscles. So that can lead to incontinence, lead to prolapse, and also sexual dysfunction. Constipation is issues, that's straining, passing hard stools. Difficulty either using the bowels or the bladder. So that's knowing that you need to go but having trouble getting it out. Urgency and then also frequency as well. So pelvic floor muscle dysfunction is where the muscles aren't working appropriately. So with all our muscles in the body, we need them to be able to contract and we need them to be able to relax. So the weak side of things and not being able to contract well can lead to incontinence and prolapse. Those muscles aren't supporting and helping when we need them to. They can go the other way as well, and they can hold on too much. And so then that can cause problems with going to the toilet as well, because you need those muscles to relax to empty the bladder and empty the bowel. So if they're holding on, that's not going to work either. That can also lead to pain, and that pain may be towards the coccyx, around in your tailbone, maybe around in the pubic bone, up into your abdominals, may go down across the pelvis, down in the legs, and it may also cause sexual pain as well. So the pelvic floor muscles do go from that pubic bone at the front all the way around to the tailbone at the back, and they fan out to the sides as well. So there is a right and a left side. There's a couple of different layers, so there's a deep and a superficial layer, and they have different roles. Muscles help control continence, so making sure you stay dry, and they also have a role in sexual satisfaction and arousal as well. So with incontinence, there's a few different types. So there's stress incontinence, which is the coughing, sneezing, lifting, laughing, jumping up and down the trampoline, exercising. There's the urgency where you need to get to the toilet but you're not making it there in time. There's mixed incontinence, which is a bit of both. Sometimes it's one, sometimes it's the other. And then there's fecal incontinence as well, and that's where you're losing control from your bowels. So that could be solid poo, could be wind, or it could be liquid if it's a bit more diarrhea. So pelvic organ prolapse. This is where either the bladder, the bowel, or the uterus starts to slip down into the vagina. It's a very, very common problem. 1 in 3 will have it to the level of the opening of the vagina or actually on the outside. We don't always know that it's there either. We don't necessarily feel it. A lot of women find out about it when they go to the doctor or the nurse and get a pap smear done with, oh, there's a little bit of prolapse in there. That might be the first thing you know about it. It can impact how you go emptying the bladder and the bowel, because if they're not sitting in the right spot, it makes it a bit harder for them to empty out well. It can feel like a lump in the vagina, so something describes sitting on something like a tennis ball in that area, or just a general heaviness or feeling like everything's going to be falling out. Depending on the degree, it can actually be reversible, so if it's quite small, pelvic floor exercise and lifestyle changes may be enough to make it go away. We might be able to just manage the symptoms and make things a little bit more comfortable for you, or it may require surgery and actually pushing things back in the right spot and having those stitches holding it in place. And it can also cause sexual discomfort as well. So I've got a couple of pictures here. The top one is what we should look like if you're cutting a down through the middle. So we've got the pubic bone at the front, we've got the tailbone coming out to the back. The bladder sits behind the pubic bone with the urethra, the weak tube coming down. In the majority of women, the uterus will sit on top of the bladder, and then the vagina down behind, and then the bowel behind through there. So in this first picture here, we've got the bladder starting to protrude down into the vagina here, and also the urethra. So they drop back. This one we've got the bowel protruding forward, and in the last picture there we've actually got the uterus starting to come down into the vagina as well. And I see women that have had hysterectomies and they go, oh well, I can't prolapse. It's like, well yeah you can. The top of the vagina where either the cervix is in place or not can actually start to fold in on down on itself as well. So previous surgery doesn't mean you're immune to this, unfortunately. And you may have a combination of all of them. So pessaries is an option for prolapse management, and it's a nice option for people that don't want to have surgery or they can't have surgery, so if they're not medically well enough to go through an anaesthetic. They're a really nice option for women that haven't finished having their children yet. And it can also be helpful when they've had their children, trying to get everything back in the right spot when they're recovering through their normal hormonal changes. So there's lots of different types. That's a few of the different ones there. And they sit in the vagina. You don't feel them, you don't know that they're there. And the type that you have depends on where your prolapse is, what it is that's prolapsing, and the degree of prolapse that you've got. So sexual pain and dysfunction, it can either be superficial or it can be deep. So the superficial might be feeling like you're ripping or tearing, and it can be related to muscle tension. So if the superficial layer of the muscles, the pelvic floor muscles, aren't wanting to stretch, you can feel like you're ripping and not wanting to let anything in the vagina. It may be related to skin conditions or infections, endometriosis, prolapse, reduced estrogen levels. So obviously if you've got sexual pain, you want to make sure that you're treating any underlying skin conditions or infections, clear that up and see how things are going. You may need counselling, so if there's any trauma that's been involved, so whether it's been a horrendous birth and there's lots of scar tissue, or whether there's been a history of sexual abuse, there may be some emotional needs that need to be managed through this process as well. And 2 out of 3 new mums will experience something, whether it's pain, reduced libido, dryness, difficulty with orgasm, and it doesn't seem to matter what sort of delivery they have, whether it's cesarean or vaginal delivery. So it's quite a common problem. So what I look at with sexual dysfunction is the soft tissue side of things. So looking at massage, whether it be sort of trying to stretch out some of those tighter muscles, looking at the scar tissue. The scar tissue doesn't stretch, so trying to manage that. Relaxation therapy and dilators. So these are a couple of pictures of the dilators that are out there. So there's lots of different shapes and sizes and colours and textures and all that sort of stuff. And basically what you're trying to do is gradually get that vagina accommodating and getting bigger and bigger and allowing you to accept penetration. So you start when you can and get to the size that you need to. So what do I do? So I look at your bladder and bowel habits, how often you go, is there any urgency, is there any incontinence, what's your stool like? So we go back to looking at that first picture. How do you sit when you go to the toilet? What do you do? What do you drink? How often do you drink? What is it that you're drinking? Are you drinking a couple of cups of tea before you go to bed, and so no wonder you're up at night time? What's your sexual function like if you're still sexually active? I look at the muscles themselves, so how much do they move, how much pressure can they give, how long do they hold on for? Is there any prolapse there, is there any pain? I've got an ultrasound machine as well, which we can look at the pelvic floor muscles that way. We're also looking at is the bladder emptying properly when you do go to the toilet. And so some of the treatments that I use with people could be pelvic floor exercises, and it may be for the strengthening, it may be reteaching those muscles how to relax again. Looking at bladder diaries, so measuring what you're actually putting in and what's coming out. Might be advising you to change some of what you're drinking and behaviours in terms of how often you're drinking and what it is. Other lifestyle modifications, so maybe we don't go to the gym 3 times a week around ovulation or something like that. That's when you're going to leave. You can modify the exercises to avoid stress incontinence. Pessaries, there's a couple of different types of pessaries that I can fit. Looking at how you go to the toilet, are there any strategies that we can use to try and make going to the toilet easier? And also soft tissue therapy, looking at the pelvic floor muscles. So essentially, things aren't working. Can I get some help?